Buenos días. Buenos días a todos. Voy a compartir mi pantalla mientras. ¿Lo ven en modo presentación?
Sí, gracias.
Perfecto, súper. Buenos días a todos. ¿Cómo están? Buenos días, bienvenidos todos. Veo muchas caras conocidas.
Good morning. Welcome to all of you. I see a lot of well-known faces, and we're going to wait for a few minutes for everyone else to connect. And as you see on the chat, we're seeing people from Tucumán. So welcome all of you. Good morning. And we'll wait for a few minutes to be sure that everyone's connected.
Buenos días, Carlos.
Good morning, Carlos.
Buenos días, Marcela. Buenos días a todos.
Para contarles, tenemos interpretación.
I want you to know that we have interpretation at the interpretation icon down below in all 4 languages of the organization. So you can go to the language of your preference. You have English, Spanish, French, and Portuguese. Again, you can find it under the interpretation icon, and you can choose the language of your preference. Again, more colleagues from Tucumán, from Venezuela, from Chile. That's wonderful. Wonderful to see that we have colleagues from every corner of the region of the Americas.
Buenos días, Roberto. Río Negro, Argentina.
I'm seeing all the people on chat where they're coming. With no further ado, and for reasons of time, I think we should start the meeting, Carlos. Yes, let us get started. Great. So I'll share, before we begin, and I give the floor to Carlos, I'd like to explain the objectives of this webinar, of this seminar, which is to present and analyze the immunization programs, the microplanning guide prepared by the Pan American Health Organization as a microplanning component, which is so important for the immunization programs throughout the region of the Americas, precisely to strengthen and emphasize the local level. They are the ones who actually play the main role in vaccinations. So these microplanning guides of PAHO sets the guidelines to strengthen the process. We wanted to share microplanning experiences with the national teams, and we will hear what's happening in Guatemala with their routine microplanning, with Paraguay with their campaign microplanning, and Colombia with their outbreak response microplanning. So it's going to be very interesting. And obviously we are in an environment of friendship and trust. So there'll be a session, open session, where you'll be able to ask questions, make comments, talk about your experiences, so that we can all share throughout the region. And lastly, to promote technical exchange and regional cooperation to strengthen national capacity in adopting and adapting the micro-planning process and its tools with the aim of closing immunization gaps, which we need so that we can return to the coverages we have been used to, but we have seen have been dropping recently. As the agenda, we have first, of course, Carlos Torre, the Regional Immunization Advisor in PAHO, who's going to say the welcoming remarks, and Carlos Castañeda, the international consultant who will present the microplanning guide. Then we'll go back to Carlos to hear about technical cooperation in PAHO and all progress in implementation. And then, as I mentioned, we'll hear the experience from 3 countries representing the way in which they have implemented microplanning in the different contexts. And then we'll have a plenary session with questions and comments. And you're all welcome to ask questions or comments either in the chat or raising your hand at the time of the open session. And there will also be, there's the Q&A session where you can make your comments as well. And then, of course, we'll hear the closing remarks talking about commitments and next steps from Hugo Rasuri, Deputy Manager of the Immunization Program, the Regional Immunization Program of PAHO. So with no further ado, I'm going to give the floor to Carlos Torres, who will say the welcoming remarks. Thank you so much, Marcela, and good morning to all. I think it's still good morning throughout the region. On behalf of Dr. Daniel Salas, Executive Manager, and Hugo Rasori, Deputy Manager of the Special Immunization Program of PAHO, it's a real pleasure for me to welcome you all to this webinar on microplanning. A silent but decisive component in the success of the vaccination campaigns in the region and in the world. As you know, microplanning is not a new strategy. It's transformed massive vaccination almost from an improvised process into an orderly process that allows us greater equity and greater effectiveness, above all, capable of reaching the furthest corners of the region, especially the most vulnerable populations. So during the 80s and 90s, this came up as a response to the need to reach the rural communities, the marginated communities, during the polio campaigns in the 2000. These programs appropriated the methodology with practical guides detailing each step, so that during the accelerated campaigns to eliminate measles and rubella during the 2000 decade, microplanning helped us vaccinate more than 400 million people in very short periods of time, identifying exactly where they lived, where they worked, what they did, where they studied, so that we could deal with these target groups. And currently, in the follow-up campaigns for diseases that have already been eliminated in our region, it continues to be essential to optimize resources, reduce gaps, of course, that we have, and above all, to ensure not only very high coverage, but homogeneous in a short period of time. PAHO, together with the health ministries today, recognize that microplanning is a strategic tool to maintain these historic achievements in the region, and above all, to face the challenges within the framework not only of the campaigns, but the routine programs, so that we can reduce the vaccination gaps and achieve access, universal access and coverage with equity, to sustain the achievements that we've reached in the elimination of vaccine preventable diseases. There are several diseases that we've been able to eliminate in the regions, and we can in this way respond rapidly to all outbreaks or imported cases that may come in of some of these diseases. That's why today we want to share with you in this webinar this microplanning guide, which deals with routine campaigns and outbreak responses. This guide was developed with your experience, the experience of all the countries of the region, and with the technical support of PAHO, documenting all the experiences from the countries. We want to review with you the key elements of microplanning and the whole process that should be developed locally, and to share with you. And here we definitely ask you to, we ask you for your feedback to hear the lessons learned and the successful experiences that in the end are going to help us strengthen our immunization programs. So that's what we invite you to share actively, to share your experiences, so that we can together consider how we can continue to ensure that each vaccine can reach each person that needs it in every corner of the region. So thank you very much for joining us in this webinar. And Marcela, I think that we can get started so as not to get too late with our agenda. Thank you, Carlos. And yes, precisely. We have teams from every corners of the region. So the idea is that this message will reach you all. Carlos Castañeda, I'll give you the floor to hear the presentation of the microplanning guide for immunization activities. Yes, thank you very much and good morning. So this is my responsibility on behalf of the special immunization, integral immunization program of PAHO, and particularly the team that works in Pillar 2, to introduce this general overview of the microplanning guide of activities, which speaks of the different strategies. So in the next 15 minutes, what I want to talk about is the history of how this guide came about. What is the purpose of the guide and the supporting tools, the objective of microplanning as a process, the different stages and steps in general, and above all, underlining the experiences of microplanning according to the EPI strategy, to end with a message about what are the requirements to ensure microplanning, successful microplanning. So as the history, we know that the special integral vaccination program of PAHO reviewed a series of documents and microplanning guides in the region, in countries like Brazil or Costa Rica, Guatemala, Colombia, and Venezuela, who'd already advanced in the use and documentation. But also, we heard of all the lessons learned in the region, in the EPI teams, and the WHO guidelines, which also came in as part of the pandemic, in response to the pandemic, as well as the guidelines for integrated surveillance of vaccine-preventable diseases. We automated these experiences. The process of the guide began with the routine EPI, and then we added all the other strategies that, in fact, was where microplanning had actually been implemented more decisively, historically, in the different immunization programs. And aside from the vaccination campaigns, the cycle was closed with the outbreak response microplanning. In this exercise of automation of the experiences, we documented a series of challenges that were common to all countries of the region, such as the need to have updated data and quality data, problems with the estimates of the denominators, and the need to disaggregate with the vaccination tactics, and essentially how to strengthen the local leadership, which in the end is where we can reach those who are still left behind. In general, we can say that microplanning is a management practice that empowers at a local level, allowing you to organize, execute, and adjust vaccination strategies in a timely and effective manner. The purpose of the guide as such is to strengthen the national EPI programs and the health teams, especially at a local level. That's where we find the center of the microplanning, so as to develop, implement, and evaluate microplanning of vaccination activities in the different strategies, which is what integrates the whole idea of the guide, which includes all the different disaggregated strategies and with some notes that I'm going to refer to later. The tools as such that have different versions for the routine program, for the campaigns, and for the outbreak response are tools that consolidate all the necessary information to program and carry out and evaluate microplanning as such. We have to recall that in the EPI components, we have the execution component quite explicit. And in this way, we must recall and again highlight the differences between vaccination strategies and vaccination tactics. And we have to consider, to begin with, that strategy is the plan that organizes long-term, while the tactics are the way in which we reach the specific connections and achieve the different objectives. So as part of the strategies, we have three big ones: the routine vaccination, which is the supply and application of vaccines within the vaccination schedule throughout the year and through the different tactics, but where the health services and other extra institutional services offer the taxes, but this is something that goes on throughout the year. Then we have the intensive vaccination, which seeks to complement that regular routine program, including a campaign days and weeks, which is within and outside the institutions, which tries to reach the largest number of people, applying the largest number of doses in the shortest period of time. And then finally, of course, the vaccination, the emerging block or outbreak response vaccination, which is when there's the presence of suspected or confirmed cases of vaccine preventable diseases to avoid transmission. And it uses the whole household tactic, which goes from one house to the other. And in this case, with the vaccination tactics, we have on the one hand the extramural, which are the ones that are applied within the health services, within the institutions, where the staff is waiting in the facilities for demand from the population. And it can also be done when the people are there at other services, integrating the services, while the extramural tactics can be a household vaccination, where the health staff goes to seek for the people at their homes, people who have, for whatever reason, not been able to be included in the regular program. And then the micro-concentration, where one identifies different spaces or places where the people might be circulating or located so that we can reach them in that way. And then the final tactic is the mobile team vaccination, where the health staff goes to the different communities, especially those that have limited access to the health services, to carry out vaccination activities as well as other type of health activities within the primary health care services. And then once we get into the actual objective of microplanning itself as a process, what we must bear in mind is that what we seek to do with microplanning, particularly at a local level, is to review, program, implement, and evaluate the operational activities of the EPI at that local level so that the population can access with a series of criteria, with equity and in an integrated way, included with the other primary healthcare services. Microplanning is focused on the actual needs of the population and is adapted to the local reality, trying to close gaps and mitigate the risk of disease outbreaks, especially those that are vaccine preventable. It's important that despite there's a single microplanning process, there's not a single prescription or recipe. There are different ways of applying microplanning, and what we give you with this guide, which systematizes the learning, is giving you a general framework so that each country and each locality can adapt it to their own context, and that includes obviously using your own microplanning tools. Microplanning, within the framework of the whole structure of the country, the administrative levels, has a peculiarity, and that is that all 13 components of the EPI, of the microplanning process, which is part of the execution component, is the only one that is exclusively local, which is found where the actual decisions are going to achieve a greater impact, because we know the community better, we know the context, the dynamics, and the barriers to access. And of course, one can intervene at that level. So it is at that level, at that very local level, where one can truly identify the most effective combination of tactics that will really achieve the true commitment of reaching the people, of reaching the population that really needs the vaccinations. And that's what makes it so fundamental. There are a series of attributes that, with the learning in the region, we've been able to systematize into these 7 characteristics for good microplanning. First, that it be realistic, that it adapts to the geographic, logistic, and social and demographic conditions of each territory. Secondly, that it be focused on people, responding to the actual needs of the population, which is the target population of the EPI, adding social listening, the analysis of the social determinants, participation of the health workers and community leaders, as well as the community in general, so that they can appropriate the microplanning process itself as well as the EPI. Thirdly, that it be viable, that it adapts to the available resources. An important part is to be able to make an inventory of the resources and realize that those strategies that are going to be implemented are truly going to close the gaps, since it was based on available resources. Fourthly, that it be clear. Microplanning has to be clear. It defines the actual target group, the activities, those responsible, during what time, and where the execution of the plan is going to take place. Fifth, that it be flexible. Precisely, the microplanning process at a local level allows for adjustments in progress, so that you can adapt it to the needs and the situations of the local needs and the actual situation of the different strategies of vaccination. It must be integrated, comprehensive. The primary health care makes it easier to access the different health services. And finally, that it be valuable. In other words, that it can be accountable, that can explain the performance of the microplanning, what was achieved in terms of coverage with the implementation of the microplanning. And of course, this is achieved based on 4 stages and 8 steps, which in general will allow us to first analyze the situation, where we actually seek to respond to a series of questions like, what information do I need for microplanning? And I need to know a series of indicators of EPI performance historically, but also at the local level. What are the resources that I have available? What do I actually want to achieve with the different strategies? What are the goals? And for that, of course, I have to have a detailed information about my population, which requires, of course, a series of evaluations of the different attributes of the population, where they're located, who are those who've not accessed the vaccination, and carry out a prioritization exercise so as to identify where I need to go first to achieve the greatest impact with my global vaccination indicators of the EPI. And also, in the second stage, what we tried to do is program. So based on all the resources available, we try to see how we can reach the different populations, the different places, what tactics we're going to use, and based on what schedule I'm going to plan to reach my population. And that, of course, depends, especially if I'm thinking of the regular program, it's going to depend on a whole year that I'm going to cover. Or if I'm actually thinking of campaign vaccination, where I'm only going to be able to have a week or a few weeks, but a clearer geographic analysis, or maybe to an outbreak response where things become urgent. So it's important to be able to detail all the resources I have available and see how they align with the goals that are set. And this is fundamental at this stage of the microplanning. In the third stage, the follow-up, which is once the implementation begins, once the microplanning begins, we need to identify what has to be measured and how, what the frequency, so that we can actually identify who's being vaccinated, how we're vaccinating the target population, which tactic is working the best of all the tactics we have available, and with all that information, be able to adjust the programming itself. We find that this is the tactic that has the greatest impact. This is not achieving the desired results. So the local level has that ability to make the necessary adjustments and correct with direct actions so as to achieve the objective. And as for evaluation, what we hope is to see whether the work plan was achieved, identify what has to be improved in the microplanning, and also what worked best and how we can implement it into the routine program, which is what we're trying to do, to strengthen all this with the different strategies, the actual routine program. According to each one of the different strategies, then, there are certain aspects that are detailed in the guide and in the tools. But what's evident is that the different strategies share the same planning schedule with different peculiarities, but it's the same microplanning, it's the same process. In the regular or permanent program, what we seek to do is to maintain coverages of more than 95% in all groups and places, homogeneously with equity, integrating all the primary healthcare services, and achieving dropout rates of less than 5%. This is based on the vaccination indicators and the epidemiologic surveillance of the vaccine preventable diseases to achieve a situation analysis and a prioritization within the routine program. And then monthly monitoring, quarterly reviews, so that we can make the adjustments of all the different activities, particularly of the tactics, so that we can actually achieve the objectives. In the preventing campaigns, which can be follow-up, up-to-date, updating, or mitigation, what's key is that it be a complementary tactic of the routine program that seeks to close the accumulated tactics to prevent the susceptible accumulations or outbreaks. And the tool has the scope can be either local or national, depending on how it's defined in the campaign, because it's not always going to be a national campaign. There could be some subnational.
It's intensive. The target population is defined in the campaign. And once again, what is key is to strengthen the routine program. In this execution over 8 to 10 weeks requires weekly follow-up in order to strictly carry it out and have rapid monitoring of vaccination in order to see that each locality has received all the vaccination and that way reach the goal. And then the response to outbreaks of vaccine preventable diseases such as whooping cough and other diseases wants to rapidly prevent the transmission of the disease. It is a focalized intervention, urgent and based on the epidemiological risk and based on local aspects. And it is limited to those areas that have a close relationship with the area or point where the outbreak occurred. And there is a specific vaccine that is administered in this case. It's a short duration with immediate execution, and therefore one wants to achieve rapid evaluation of the impact and lessons learned. Once again, this is going to reinforce the program, the routine program. And in closing, what have we seen in the region's experience as a requirement to ensure that microplanning is successful? First, you need the political will. In other words, high priority to immunization with a legal framework guaranteeing resources not only for vaccines but the entire program, actually. Microplanning itself identifies the consumables and resources that are needed in order to reach the population. There also need to be clear guidelines and policies adapted to the national context, obviously, but also correlated with the local reality, because that is where you're going to be implementing the guidelines. it needs to be integrated with the vaccination activities of the PHC, with the participation of local legal leaders who will facilitate access to the population and will also increase confidence, not only in the vaccines but also in the health services. There needs to be a strategic communication, and this is very relevant there. These are some of the activities books and publications that can be found on the website of PAHO and SIM in particular. It has the guide and the supporting documents, and all of these are available to you. Thank you very much. Thank you, Carlos, for that presentation. Let me suggest to the audience that they write down their questions, which will be answered during the plenary. Without further ado, Carlos Castañeda, please stop sharing the screen and let me offer the floor to Carlos Torres. Thank you, Marcela. I'm going to share my screen. Can you see it in presentation mode? Yes. Very well. Very rapidly, and in continuing what Carlos was presenting, let me talk about the advances in technical cooperation on a regional level when it comes to implementing this tool. I will rapidly refer to the strategy that has been adopted for implementation. This has been done with countries, the progress achieved regionally, and the challenges and next steps. Implementation basically is being done in 3 phases with the countries. First, this is work that has been carried out virtually because we wanted to provide a context or obtain the context for the country, understand their management, the flows of information, which vaccination tactics have been employed in the country, the target population, as well as the country needs when it comes to certain variables or what they want to enhance in program performance, whether it's children and 2 or follow-up or achieve homogeneity. So find the key aspects in each case and create a work plan. This might take 2 to 3 weeks. This is a process that is carried out through virtual meetings with the health teams. Once all the elements have been gathered, the tool is adapted, and we continue holding virtual meetings to see if the adaptations being made to the tool are those that are helpful to the country. And then the tool is tested through a pilot at some health center. And this is done either at the national or regional level, or sometimes even local levels, to see if the tool really works and how the information flows. On this basis, progress can be achieved in the process. Phase 2, which is more in person, we provide support from headquarters with implementation workshops, training trainers first, and then transfer that training to the local level. And here it is very important to consider the following. We have seen that there are some elements that need to be reinforced at the local level, especially given the regular turnover of health workers. So it's very important to reinforce some key aspects of the immunization program, how to achieve coverage, what are the access indicators, and the follow-up indicators, the dropout rates, and not only how these indicators are calculated, but furthermore, how to interpret them. and even going beyond interpretation, what further action they require from us or what assistance from us. So in the training, all these elements are reviewed, and then we start working on tool implementation at the local level. And these workshops are not purely theoretical, but actually, at this point, we start to populate the tool to see how it actually works. This implementation in some countries, it could be by departments or by provinces or by priority states. And in the case of other countries, it might be national from the outset. The third phase is monitoring. The tool allows us to move forward. Obviously, supervision is crucial. This phase is normally done remotely, but if the country does ask us and wants to expand to other territories perhaps, or to readapt the tool, then we could once again coordinate visits to the country in order to see the lessons learned and the results obtained, and in particular identify the best practices so that that can then be extended to the entire country. Results are analyzed to see how the tool is being added to on a daily basis, and then also look into future planning, what adjustments are needed to the tool in order to achieve the objectives set by the country. Advances in the country. In green, you can see those countries that have already implemented the tool. As I told you, in some cases, it is only in prioritized regions, and in other cases it's nationally. Maybe some countries began with some departments or provinces that were priority areas and then expanded it. Ecuador is in pale green because they have a very interesting situation in this country that made it possible to adapt the tool of the country already had, but they adapted it to the 4 steps that Carlos explained a while ago. Let me also point out that the guide that is finalized, and we have an a version right now, and hopefully in the first quarter of next year we'll be able to share the publication of this guide with all countries. But throughout this process we will continue providing support to you all in order to meet all of the steps. Another exercise that was very positive for us in the region was St. Vincent and the Grenadines. Let me explain why. It's not the same to look at the Caribbean region compared to the continental ones. So here we adapted the tool and were able to see that it is also useful to Caribbean nations. In addition to routine, we work on campaigns also, specifically Paraguay and Mexico that have a vaccination campaign for measles, rubella planned for next year. But in October, November, and even December of this year, they have started with the microplanning exercises. And Colombia, that will be presenting in a short while their experience in the microplanning for outbreaks, in particular yellow fever, and now they're applying it to whooping cough. Now, what are the challenges that we see? Well, first, the tool needs to be standardized at a national level. It is a tool that is useful for the health unit, but nationally it is necessary for it to be standardized in order for them all to be assessed in the same manner and to ensure that application is universal throughout the country. Gradual improvement, obviously, of the population denominator. When the tool is used locally, the indicators can be improved. One of the challenges we face is the denominator, and when we look at it through the health unit, there is even greater challenge to know exactly what is the population living in each territory. Recognition or knowledge of the territory is also a major challenge. Where are the limits for each health area, and what is the population living there? But as we continue implementing this, adjustments can be made. Another point is to move from Excel to nimble digital solutions into connecting the information systems to this tool, which will facilitate its use. Then the local levels will be able to see that they have a nimble, flexible tool that is easy to manage. Lastly, training and follow-up of microplans in the field is crucial, not only to learn from the experiences and to see what challenges were encountered, but also see where greater emphasis needs to be placed, such as training human resources or having additional human resources, strengthen the cold chain, seeing what logistic elements are needed in order to truly ensure access for the entire population. Closing now, for microplanning to become sustainable, it is essential that it be part of the technical and administrative standards of the EPI. It has to be a standardized tool allowing the country to measure uniformly all their health units. It has to be consolidated as a daily working tool at the local level. The local level must be empowered and know how to use the tool. And obviously there has to be a follow-up from the higher levels to strengthen those areas that can be improved. And obviously it is necessary to have active national involvement from the central level throughout the implementation process. What impact are we hoping to achieve? As I said, in some cases, the tool has been implemented nationally. And in these countries, perhaps in the first year, we will be able to see if the tool is approved, local levels take ownership of it, and reinforce and strengthen the capacities of health workers. Perhaps in the second year we'll be able to see the results. And we need to be very clear about this. Implementation of the tool is not a magic wand necessarily, but it will necessarily result in change, not only when it comes to coverage, but also in the work dynamics. And that is what is so important. And in those countries where the tool is being adopted in a scaled manner, then, or staggered manner, these results will result over a longer term. But it will all depend on the implementation's pace and how the phases are consolidated and the type of support that is being given at the local levels. The clear message that I want to convey here is that microplanning needs to reach every person in every region. Thank you very much. That was wonderful, Carlos. Thank you so much for the presentations. Once again, I ask you to write down your questions. We're already seeing some in the Q&A area. We will be looking at them after the country presentations. Very well. So let us now see how we move from theory to practice, and we're going to start with the experience of the Guatemala team. Ms. Sandy Cano is invited to give this presentation about the experience of the use of microplanning for routine vaccination. Thank you, and good morning, and I'm going to share my screen. Please let me know if it is now showing clearly. Yes, it's available to us all now. Very well, good morning, and it's a pleasure to join you today. And I'm grateful for this invitation to share with you the experience in Guatemala in the implementation of microplanning in routine vaccination. The process began in February and March of this year. And several meetings were held with the Guatemalan PAHO office, and there was an expression of interest in deploying the instrument nationally. And that is because in the country, microplanning had been used for campaigns, in particular for measles, rubella, and polio. So what we wanted to do was use this tool for the routine planning. And this was truly an opportunity in order to deploy the system throughout the country. To begin the process in March of this year, the program with PAHO support conducted an exercise as a pilot at one of our department centers of integrated health services networks, in particular in the Misco community. In this office, a pilot was conducted, an exercise, to put into practice the implementation of the tool. And this application with real data and applying it in situ at a health center developed some ideas for adapting the tool to the needs of our country. Let me also point out that all the support we received from PAHO has been to improve the tool, adjusting it to our own national context. In June, an update workshop was carried out for the guidelines and planning of the work of the vaccination campaign, targeting the 29 department offices of these integrated networks. There was an opportunity here to talk about the concept and implementation of microplanning in routine vaccination activities. This allowed us to introduce the topic of microplanning at a national level, and that is where we started, by making it known to all the different offices, letting them know that we had a tool available that would allow them to reinforce the activities that they had already been conducted, and that this was going to be shared with all the different units. In June of this year again, planning began in order to arrange workshops to make the tool known to everybody before deploying it nationally. We have approximately 371 municipal districts for health services. So our goal was to make it known throughout Guatemala and all these services, and the logistics was going to take extra time. That is why it was so important to have a detailed plan in place. This was the first time that nationally we were going to bring together the 371 representatives of the health municipalities, and they would be participating in this program. I also wanted to let you know that in this exercise, what we were seeking was to compare with real local data from each municipal district. So what we wanted to do is ensure that the health services had the most up-to-date data so that the exercise as carried out would be the better adapted and adjusted to the local context. Planning received support from the country office of PAHO in Guatemala. There were also some virtual seminars bringing together the 29 entities responsible for the different departments and networks of these health districts to look and analyze at the data that would be key and crucial so that each health municipality district could be able to share it. So in Guatemala, I wanted to let you know, we do have 29 departmental services of integrated health services networks. Of these 29 offices, there are 371 municipal districts reporting to them, and they are the ones that participated at the workshop. In August, on 6 and 7 August in particular, a first workshop took place for national implementation. The purpose of this workshop was to train trainers who later would support us for deploying the microplanning tool, making it known to the different health districts. At this workshop, we invited a person in charge of the immunization program and one epidemiologist in order to achieve access to all the teams and have them know how to use the tool. All epidemiologists were approached because there is some surveillance in the tool, and we needed also to have risk analysis. This had to be done. In 11 through 29 August this year, 7 training workshops were offered to make known all the microplanning tool, to make it familiar, so that later it could be deployed nationally. At these workshops, and again there were 7 that took place simultaneously, 29 responsible from the DRIS, these are the integrated networks, and 371 responsible for the health districts were invited. We had the immunization program chief, the DRIS epidemiologist, and one person responsible for each health district immunization program. At these workshops, participants filled out the microplanning tool with real data, which strengthened or reinforced their technical knowledge, consolidated the necessary adjustments to guarantee effective implementation of the tool nationwide. As you can see on the images on this slide, for this logistical support, we did receive strong support from PAHO Guatemala as well as regional PAHO. Thus, these 7 workshops took place providing training. This was hard work. You can imagine to have so many people here working on this logistics does obviously require careful coordination. Now, where are we today in Guatemala when it comes to microplanning implementation? In September and October, with technical support from PAHO Guatemala, we developed a document describing the plan of activities, monitoring and follow-up of the routine microplanning tool. This plan is key for us. It provides a roadmap of what we're going to do and how we're going to ensure systematic use, quality of data, and continuity in the microplanning process at each health municipal district. It also guides as to the technical support to be provided from the central level or from the department level for evidence-based decision-making, and especially ensure that microplanning is fully used so that it becomes effective in the operations of each health center when it comes to vaccinations. Among the activities for monitoring and follow-up of implementation, we started by sending a letter to the Directorate of the Integrated Health Services Networks, the DRIS, where we stated that after the workshops, the tool would be shared with them for them to put it into use and complete the form, enter the data. This would lead to step 2, tool adjustments, and that is where we are right now, again with PAHO support. Each municipal health district is filling out the tool, the forms, and send us their contributions, which they believe are important for the tool to better adjust to their needs. A future step will also be to create a national dashboard to consolidate information automatically from the municipal district right up to the central level. With this, we'll be able to visualize in real time all the information provided by the municipal health services. It will also strengthen the central capacities from the different units at the departmental centers to allow us for nimble monitoring to see any lag, areas where there is lagging problems, or to provide the support and training that the health providers require. It was also important to provide annual reinforcement in use of the tool. This is done through virtual webinars. We emphasize this here because in Guatemala, we do have a strong turnover of human resources. Through these webinars, we are therefore able to guarantee an opportunity to identify gaps, to compare progress between districts, to have interventions and guide actions, and in particular, train the personnel in a continuous manner in the use of the tool. The monthly analysis of results will allow us, through reviewing microplanning, to have data turn into concrete decisions. Field monitoring will allow the central authorities, as well as the department authorities, to ensure or see which area requires technical support, strengthen local capacity, and ensure that microplanning can really improve the service. Something very important is to consider integration in the guidelines of this microplanning tool. We do believe it is important that when the microplanning tool is integrated in our policy as a national immunization program, we are actually achieving better institutionalization of the tool, which means greater acceptance, and this obviously will translate into coherence that is adjusted to our standards and processes, thus strengthening the program at the national level. What opportunities are there to improve the tool? As I told you a moment ago, it is important for the municipal health districts to tell us what adjustments they need, what improvements they could contribute to the tool. With support from PAHO Guatemala, we are transferring the comments received from each of these districts. Among them, I could mention that the tool does have tabs for carrying out certain tactics, especially requested by the health services, and they want these tabs to be increased to 12 visits. There are municipal districts that visit certain communities frequently and have some interventions on a monthly basis. So they would like these activities to be documented in the tool.
We're also considering including something against flu, especially people over 60, so that it could be considered an indicator for the whole cycle. And there are other adjustments that we've added in recent weeks, and it will be important with the support of PAHO for us to be able to continue to advance so that with regional PAHO we'll be able to see this as well. It's also important to mention that we've had difficulties in detecting mistakes in the filling in, which could be configured in other tabs of the tool. That was also reported to the different municipalities. And something very important as well is the desired transition to software instead of Excel of the tool. Of course, the Excel has supported us throughout many years, but we should mention that the Excel does not allow us to really validate the information, nor can we block inconsistencies or certain tabs that could affect the final results. Ideally, the tool should evolve to a type of software where we're able to do automatic validations with protected fields, a structured upload of data, and a dynamic generation of reports. And I'm going to mention this because at some point maybe PAHO could give us some type of support so that we could develop some type of software. We'd be more than welcome. We know that this takes time, but without a doubt, this will be very important to have. And lastly, I'd like to end. Thank you. I'd like to end by showing you a brief video of the documentation we're obtaining regarding the microplanning issues in our country.
Ahora les voy a compartir el video.
I'm going to share the video with you now.
Han apoyado, ¿verdad? Nos han dado.
They've supported us. They've given us
A nivel de departamento hemos
at
trabajado
the
de la mano
departments.
con
We've worked
UPS,
together
que
with
nos han dado
PAHO,
la oportunidad
who've
para
given
poder
us the
implementar
opportunity
muchas
to implement
estrategias
many
específicamente la
strategies specifically
microplanificación,
for
así como
microplanning,
también insumos
as
y
well
recursos
as
que ellos
input
nos
and
han
resources
apoyado,
that
¿verdad? Nos
they've
han dado
supported us
para
with
poder mejorar lo que es
to
el programa de
improve the
inmunización.
immunization program.
La microplanificación tiene esa ventaja.
Microplanning has that
Nosotros
advantage.
ingresamos todos los
When
riesgos
we
que tiene
input all
la
the
comunidad,
risks of the
automáticamente
community,
nos
it
prioriza. En
automatically
esta ocasión,
gives
pues
us
nos
the
priorizó
priority.
comunidades que
And in this
nosotros ni
case, it
siquiera
gives us
imaginábamos
priority
que
of,
iban a estar
of
en
the
riesgo.
communities we didn't even
Como UPS,
imagine were at
nuestro
risk.
objetivo es
At
brindar
PAHO, our
apoyo
objective is to
técnico
offer the technical
y
support
fortalecer las
and
capacidades del
strengthen
personal de salud
the
a nivel
health
local
workers'
para
capacity
el uso de
local
la herramienta
so
de
that they can use the
microplanificación para
microplanning tool
actividades de vacunación de
for
rutina.
routine vaccination activities.
Tenemos poblaciones
We have
renacidos vivos, menores de 2 años,
populations
menores
of
de 3,
under
de 4 y de
2, under 3,
5 y
under 4, under 5
niños
ages,
por
and we
años.
have
Entonces,
been working with
dependiendo
them for
cómo vayan
years. So
llegando
depending
las
on how
cifras con la
we
táctica de hacer
receive the ladies
concentraciones,
with the
nosotros
concentration
estamos
tactics,
lo que son
we
listados de
do
niños
list
pendientes
of children
de
that are
vacunas,
pending vaccines,
identificación, peso y talla, y
weight,
gracias a
height,
ese
and all that.
listado
And
nosotros
thanks to
tenemos
that list, we
identificados a las
can locate
familias para ir a
the
hacer la
families so that we
búsqueda
can go
de los
and
niños y
look for
lograr
the
la
children
cobertura
and
en
achieve
acompañamiento de los
coverage
líderes comunitarios
together
de
with the
salud.
community leaders.
Uno como representante
As
legal de la
legal
comunidad se
representatives
siente
of the community, we're
agradecido porque
grateful
realmente
because
hay que ir al puesto
we
de
actually
salud
have to go to
cuando
the
se
health
siente un
centers
poco
when we
mal con
not
gripe,
feel
con dolor de
well, we
cuello,
have
todo eso se siente.
aches or pains or a cold.
Pues invitamos a toda la
So we want to
población
invite the
específicamente
population
para que llegue a cada
to
uno de los
come to
servicios
all
que
the
se
different
encuentren
services
para poder
so that they
vacunar a cada
can
uno de sus
have their
niños.
children
Y
vaccinated.
decirles, ¿verdad?, que es
And we tell them
esencial
that
que
this
los
is
niños
essential that the
se
children
vacunen,
should
que los
get their
niños se
vaccinations
inmunicen, porque
and
mediante ello
be
vamos a
immunized
prevenir
because
muchas
it is in that way that
enfermedades
we're going to
y que
prevent many
gracias pues al
diseases, and that
Ministerio de
it's
Salud
thanks to
junto a
the
la
health
UPS
ministry and
podemos
PAHO that
nosotros
we're able
darle esta
to
oportunidad a cada
offer
uno de
them
estos
this
niños para que
opportunity
sean vacunados.
so that they can be vaccinated.
He vacunado a todos mis hijos, desde el primero y hasta esto.
I mean,
Y
I
por eso es
vaccinated them
importante,
all
¿verdad?, que
because as
uno
I
vaya
realize it is
hacia
important
el
to
puesto de salud, que
go
uno
to the
participa
health
en eso.
centers.
La importancia es que
What's
no se
important
enferman
is
y
that if
nunca veas bien la enfermedad
that they not get
por eso es
sick,
que por eso la protección para ellos.
and this is
Invitamos a toda
protection
la
for them.
población a que llegue a estos servicios de salud más cercanos.
We offer this to all the population, these health services.
Muchas gracias,
Thank you very
Sandy,
much, Sandy,
por reflejar todo el trabajo
for
que
showing us
se
all the
está
work
haciendo en
that you're doing in
Guatemala
Guatemala
términos de
in
microplanificación de
terms of
rutina y cómo
the
eso
routine
ayuda
microplanning and how
a
it
la
helps
población. Así que
the different
felicitaciones
populations.
y
So
muchas
my
gracias por
congratulations and thank
compartir
you
esta
very much for
experiencia.
sharing that experience with us.
Bueno, Pablo, te paso
And
la
now I'm going to give the floor to Pablo, who's going to talk to us about their experience in Paraguay with the use of the microplanning tool for campaigns.
Sí, muy buenos días para todos.
Good morning to all. And if I can you tell me if you see my screen? Yes, there you go. Thank you.
Voy a minimizar un poquito aquí. Ahí está. Bueno, antes que nada, muy buenos días a
So
todos.
first of all, thank you to all the colleagues who were
Quisiera presentar un
present.
poquito
I'd
la
like to
experiencia en el
tell
uso
you
de la
briefly
herramienta
about
de
our experience with the
planificación
use of the
para control
microplanning
de
tool
seguimiento
for
contra la
the
rubéola
follow-up
hecho
campaign
por
against
Paraguay
the
del
measles and
proyecto para el
rubella in Paraguay
2026,
for
el mes de marzo
2026, in
del
March
año
2026.
venidero, donde tendremos nuestra campaña nacional
We'll
de
have
vacunación de
our
seguimiento contra el
national
sarampión y el
follow-up
papaporro.
vaccination campaign against
En este
and
marco, pues, ya
measles.
tenemos los
And in the
antecedentes,
context, we
aspectos
have the
generales de la
history, the
microplanificación,
general
la
aspects of
metodología y cuáles
microplanning,
son los próximos
methodology,
pasos
and next
a dar
steps
continuidad a todo este proceso.
for
En
continuity of
cuanto
the
a la información
process.
geográfica,
As for
demográfica y
geographic,
socioeconómica del
demographic,
país,
and social
podemos mencionar
economic
que
information, we
tenemos
can
18
mention that we
regiones
have
sanitarias, 18
18 health
departamentos en el
regions or
país,
departments
con
in the
un total
country,
de
a total
363
number of
municipios o
263
distritos
districts or
distribuidos en todo el territorio
municipalities
nacional,
distributed
y la
throughout the
población total
territory. Total
asignada por el Instituto
population
Nacional de
assigned by the Statistics Institute for 2025 of 6,372,623 inhabitants. From 1 to 5, which is our target population for the campaign, 496,293 children, a rural population in 2022, which is above 1.8 million. Health establishments, 1,415, and vaccination posts, 1,346 throughout the territory. As for the history, it's important to mention that in 1980, we created the EPI program in Paraguay, and in 1994, Paraguay joins the objective of the regional elimination of measles. In 1998, we had the first national elimination campaign for measles for children under the age of 15, and the last endemic case was in that year. By 2005, we had our national vaccination for the elimination of rubella and the congenital rubella syndrome for children from 5 to 39. And that was the last year where we had an endemic case of rubella. In 2016, we received the certification of measles elimination. In 2021, a follow-up campaign. And in 2025, we are planning our follow-up vaccination campaign for measles and rubella for 2026. We planned it for 8 weeks, which will begin March 2nd, 2026, which will extend to 25th of April of next year. In our follow-up vaccination campaign, we have first defined our target population with the technical and operational guidelines available in our national vaccination campaign, manual use for the vaccinator, and to work initially with the follow-up campaign microplanning in Paraguay in 2026. As for the target population, as I mentioned, it's to close vaccination gaps to maintain the elimination of measles and rubella in the country. As I mentioned before, we want to cover 100% of the children from 1 to 5. We have the presentation of the vaccination that's going to be used, the geographic scope, which will be throughout the country, and in time, as I mentioned, it'll be 8 weeks. As far as the general microplanning aspects, we recognize that it's important to have the basic inputs to plan all the activities, focusing on the needs of the population, and understand that microplanning is developed and initiated locally. It should not be regionally. And especially for a national vaccination campaign, it's very important to identify the gaps, the barriers, and the real situations of each health services distributed throughout the country so that we can focus our vaccination guidelines according to the risk areas that we can determine with the tool, the efficient use of resources, the involvement of the community, and the local governments. It's important to have them join, the local and municipal governments join us so that we can actually achieve the empowerment of the health workers with the feasible access to services. It's also important to mention that we have been working with our 263 municipalities in the country to deal with situational analysis and programming, which are fundamental guidelines for the history and for the vaccination campaign. Now, during the actual campaign, we have the follow-up stage where we'll do administrative and rapid vaccination monitors, and then at the end of the program, the evaluation of the process. Methodology, it's fundamental to adapt the PAHO tool to the national context. It's important to identify the realities of the countries. These are all very different, and that's why it's so important to, before showing the information at the local or district or regional levels, it's important to adapt the tool to the local realities of the country. A pilot test is important to obtain or identify the actual realities of the services, the reporting and the information with the local support. Without the local support, this is not going to be possible. That's why it's important, once we do the pilot test, to talk about the methodology with our local actors, who are the references we use for governance in the country, and then prioritization of the regions. It's important to prioritize this, and we begin this by prioritizing the health regions that will receive greater emphasis to deal with the task that we're trying to carry out here. Because nationally, we're able to get the support and constant follow-up of all the health districts, but we know that there are some health districts that are the ones that move the coverage in our region. And then the implementation of workshops per services, per health service. It's important to be there with them locally, to talk to them, to make the local region participate and understand the importance so that they can input the data, extract the information, analyze it. With a theoretical workshop alone, that's not going to be enough. So we prioritize the health regions. The red and the orange are the ones that represent basically the 70 or 80% of the target population that is going to be included in our national vaccination follow-up campaign. That's why it's so important to identify what regions are the most important in number and in actual coverage of the target population, which is distributed in those territories. We had a national workshop, 19 regional workshops, a total of 66 workshop events with the participation of more than 2,300 health workers. And not only in the vaccination area, but in all the different services and districts distributed throughout the country. As for the topics discussed in the workshop, we talked about the technical and operational guidelines of the vaccination campaign with fixation exercises, mainly to understand and observe whether the local team is actually understanding the information that we're conveying. That's why it's important to do these fixation exercises, to consider the different scenarios that could arise in the field, so that all those who are working understand the guidelines of the microplanning and they socialize the tool. 16 in-person workshops and 1 virtual done by the EPI. And we've also allowed for the health districts to be part of and appropriate these microplanning workshops. We've had 2 health regions that have joined, and they themselves have been able to download the information and report it to all their health services. As for the number of participants, we called in the EPI heads, the regional EPI heads, the district EPI heads, and it's also important to, and this is what we've done at the workshops, is that the responsibility is not in the hands of only one person or one health service, but the whole team that is available and working in the field. These are some images of some of the workshops that we held in the central department that includes about 50% of the target population that's going to be included in this campaign. This is the capital. These are the regions in the interior, Paraná, Itapúa, San Pedro. And we identify and download information, which is what we give the services, saying that microplanning of the campaigns helps us determine the best vaccination tactic to be used, because historically, a vaccination campaign is related to an exclusive vaccination campaign in the field. So we've talked to the local teams and spoken of the need not only to include the active vaccination campaigns in the field, but to have an registry of the vaccination, making it more feasible for us to deal with many of the different vaccination tactics, and use as the starting point our educational institutions with the micro concentration of these, so that these should be the most effective tactics to reach the target population. We also have weeks during which we seek our population with our registries, where we've identified the phone numbers of the children or the parents of the children who are in our registry, so that we can call them in so that they come into our vaccination centers. And as for next steps, the success of good microplanning is an appropriation of the tool, follow up on it, and I think that's probably the most difficult challenge, which is to follow up and make sure that the health district or section feels part of the program, that they appropriate the tool and realize their own realities. Follow-up, we're currently in the process of verifying the microplanning tool sent to us by the health services and with the help of the EPI, so that we can adjust the actions to be considered throughout the process. That's all for me. Thank you very much. Thank you, Pablo. Very interesting to see how you are planning and organizing your next campaign, which is a tremendous challenge. And now I'd like to invite Jacqueline Palacios from Colombia, who's going to talk to us about their experience in the use of the microplanning in outbreak responses. Jacqueline, are you online? Are you there? Fernando González? Are you around?
Sí, yo estoy y ya que no
Hola,
está.
sí, ya. Que no
Adelante.
nos habían dado audio. Muchas gracias.
Thank you. I was just trying to get my audio. Thank you very much to all of you. Jacqueline, do you have a presentation you want to share? Can you share the screen?
Doctora Jacqueline, por favor.
Dr. Jacqueline, you have to accept to be a panelist in order to make a presentation. Otherwise, we won't be able to share the screen with you. Okay.
Muchas gracias.
Thank you.
Perdón, Marta.
I'm sorry, Marcela.
Ya está como panelista.
Now you are as a panelist. Now you can share your screen. Jacqueline, see if you can share your screen with us. Yes, ma'am. I'm working on that. Greetings to the region. And we're going to explain the microplanning process for the yellow fever outbreak. Jacqueline, we still don't see your screen.
Estoy tratando de subirla
I'm trying
en
to
este instante, si me permiten.
share it right now, if I may. Okay, I think we're sharing now.
Bueno,
There you go. Now we're ready.
muchas
Thank you,
gracias,
Jacqueline.
Marcelita.
Yes, thank you,
Bueno, quería
Marcelita.
comentarles que esta es más la
I wanted
experiencia
to
del
tell you
programa
that this is the experience
Bioinmunización de
of the
Colombia,
EPI
del
program in
proceso de
Colombia
gestión de
and the management
microplanificación que
process for
hemos
the
adecuado
microplanning
para
we
brote de
adapted
fiebre
for the
amarilla
yellow
cuál está
fever
pasando en
outbreak,
nuestro territorio.
which
Y
we
para ello
have in
quiero
our
contarles
territory.
que
And
habían
I'd like to tell
elementos
you that
esenciales de la
there were some essential
microplanificación que nos
elements in the
sirvió
microplanning
para
which helped
poder
us
dar respuesta a este
respond
cambio
to
epidemiológico en el
this
país. Uno de ellos es
epidemiologic
que era
change
que
in our
teníamos
country. One of them was that we had
lineamientos y
theoretic
lineamientos de vacunación
and
presentes
vaccination
y esto
guidelines
nos ayudó
which
en el
helped
proceso
us
de organizar la
organize the
microplanificación. El país tenía una
microplanning. The country
microplanificación,
had
unas herramientas y tenía
microplanning
ya
and
previamente
tools
algunos
and
talleres
some
abordados que
workshops
nos
that had already
facilitó
been
el proceso de los gerentes
attempted
del
to
PAI para
help
llevarlos en práctica
with
con los
the
equipos
EPI
como ustedes
managers
están
and
viendo
the
en esa
implementation with the
lámina.
teams, as you
Y
see on the slide.
tercero, lograr
And thirdly, we were
coberturas
able
de
to
vacunación
achieve
en una población
vaccination
vulnerable en
coverages in
pleno
the
brote
vulnerable
nacional.
population in the
Para ello,
midst of the outbreak
el
itself,
propósito,
for
vuelvo y
which
retomo
the
lo de mis
purpose,
antecesores,
as my
definitivamente
colleagues
es
also
mirar y
said,
unificar los
the
diferentes
important thing is to
niveles de
see and
gestión
unify the different
para
management levels
que
so
nos
that
unifiquemos
we
desde el
can unify,
establecimiento de
we can
salud, desde el
join in the
vacunatorio, desde
health
el punto de
center, the
vacunación y el
vaccination center,
proceso
the
de
vaccination points, and
microplanificación
the
y alcanzar una
microplanning
meta que
process so that
tiene
we can achieve the
un
goal
importante proceso de salud
which
pública que es
has
el
a public
control del
health
brote. Para ello
idea, which
hubieron
is the
elementos
outbreak
esenciales
control.
de la
We had essential
microplanificación,
elements of microplanning included. We began with a consensus plan, negotiation and management of the tool we had, defining the tools of when and where, how we could reach the goals, schedule the teams, the vaccinators that were going to go out to control the outbreak every day, and to use the lessons learned in the region and in the country as sources of information for us. In the outbreak, which is our presentation, was done initially at the local level, starting with the resources we had available and trying to understand what are the resources were necessary. So with this outbreak control, we saw our existing dynamic of the virus in the region. We use the georeferencing documented sweep to activate the vaccination campaigns. We did verifiable implementation, monitoring the activities, and we did the guideline of the monitoring so that we could evaluate the vaccination processes continuously. Now, the purpose of having the microplanning during the outbreak is definitely to control and reduce morbidity and mortality. And in the country, the microplanning cannot focus only on the IPS or the vaccination center that is going to carry out the vaccination process. This is an outbreak throughout the country, and we have to have several actions with priority zones. We have to join the municipality, the department, and since it's a national outbreak, the state of Colombia has to deal with this nationally. So our first step in microplanning, as you see on this slide, of the operational key was to plan all actions at the level of all actors in the communities, obtaining the financial resources and complement them. Because, it's one thing to have a plan of action for a year, and another thing is to have a national outbreak. We have to locate the strategic vaccination populations, recognizing that we have an endless number of different territories. We have to schedule the vaccinations and promote without leaving the rapid vaccination program behind, because that would guide the vaccination teams as well. We had different tactics extramurally. We had the basic documents like the documented sweeps, like vaccination tactics, vaccination journeys, school programs, and the monitoring was essential so that we could find the vaccinated and unvaccinated populations and determine the risk. I'm going to show you the risk classification within the framework of the Resolution 691 of 2020, which I'll explain. This was the framework resolution for our outbreak, but the country verified what were the high-risk municipalities, high risk and very high risk, and low risk. So we had to work with other public health groups to determine the active circulation of the virus, if there were human cases, epizootics, or an epidemiologic corridor, or what have you. On the map, you can see in the red are the municipalities which were considered high risk, which were an important section for outbreak control. Then in the yellow, as you see there, those are the high risk, 251 municipalities in the country who didn't have any active cases, but had all the necessary conditions to allow for the cases to appear. And in green, the low risk, 719 municipalities, which didn't have any condition to find the outbreak, but where there was a high circulation. This is the first part of the microplanning, which was to really analyze the georeference behavior and the circulation of the outbreak. For this, we had a public health governance process where we checked with the Strategic Health Committee, unified post, where we began to work with bulletins to organize contingency plans and territorial response, and the new guidelines, vaccination guidelines for adults over the age of 60 to 69, which we did not have. And then all the different actions in the Cordillera, which we were using to determine the displacement of these communities and to place all that information all that regarding the microplanning to determine that the high-risk population, the very high-risk population, was the one that was in agriculture mainly and doing different types of agro activities, and were in the risk evaluation centers. That helped us declare the health emergency, and that led to the actual process. Here I can show you that with each microplanning that was done for yellow fever, we found differences by site and by place. You remember the three categories that I mentioned? Each one of them has specific actions. Some very high risk, for example, have susceptible populations that were being vaccinated, and it was dropped after 9 months, from 9 months of age to over 59 years of age. And this was analyzed together with the Pan American Health Organization and with the help of the World Health Organization as well. We implemented the block, the documented sweep, the microplanning as actions to achieve full vaccination coverage and massive vaccination in all the sectors, where we have different sectors of the country working to achieve this process and to contribute to entering the national parks as well. This is the high risk. As you know, it has epidemiologically certain determinants that we can follow for the microplanning, and we planned an intersectorial massive vaccination. We talked about vaccine blockage, but with a very important aspect where we had no health controls, but we did get the request for the vaccination. So at the different levels, the vaccination is differential. And the low risk are the ones that do not have the epidemiologic conditions, but which could travel, displace, could enter the risk areas where definitely they would have to continue with the microplanning actions like the rest of the country. All Colombian, every citizen that goes to these high or very high risk areas must follow the vaccination planning. In summary, the information required for the microplanning preparation at the different levels was to evaluate the target population, see the documented sweep, check the municipality and the risk and the identification of the process, to develop maps by georeferencing sections or areas to determine exactly how we can reach all these. This was the initial phase, which was required, different tactics for vaccination by ethnics and area aspects where the population was focused, with a description of the residents, with a description of the migrants that were arriving, checking the list of local leaders we had, and the list of supplies. So microplanning available for outbreak control in the country. And as they explained before, we respond with what we need, what is required, what is the results we expect in the 3 stages: situation analysis, follow-up, and monitoring.
Each one has its steps and products, and those are things we need to achieve. Based on this, we had a situation analysis. We've shown you the maps. We saw which were the vaccination centers, human talent, and control. For us, outbreak control through microplanning was focused on the documented sweeps, seeking to identify who were and who were not vaccinated and how we could count them and capture them. Through the sweep, our teams were sent out to the smallest communities. This could be those areas that were most remote, most difficult to reach, and we made available the human talent to help us reach them, plus providing them with a vehicle. We have maps broken down by the smaller sections, and that way we now know who is and is not vaccinated. For this, we had tools adapted through microplanning so as to identify by housing, by sector, what population existed there and what kind of follow-up is being provided. Programming shows what we need, what we want to do, and what's the output, and also verify the ages. And as I told you, we changed the dynamic for the governance, defining which group needed to be vaccinated, depending on the areas, and the strategies to reach them in order to achieve a 95% coverage. Each group had its monthly or daily determination of activities. Jacqueline, I do apologize for interrupting you, but I would like you to please conclude your presentation. Microplanning shows us the vaccination in different environments and territories, how to work in order to organize actions, and we developed maps for all the processes, asking our teams to describe the type of population they were vaccinating. We wanted to ensure compliance, verification and support for all leaders, as well as the nurses and doctors who were controlling outbreaks, presented the progress in microplanning and the positioning on the political agenda of the local government as to the response to outbreaks. These are the true leaders of microplanning. They plan, execute, go to the areas, work with ethnic and religious groups, those who never give up. So our evaluation has a control table divided by municipality, by department, which we verify on a weekly basis to see what kind of coverage we have achieved. Evaluation is extremely important to understand performance, especially when there is an outbreak. Active participation of sectors allow us to ensure that there is intersectoral participation and involvement. Risk control is necessary for control and for this information to be deployed to all the communities. And lastly, to achieve vaccination coverage as urban, such as you see here, and also to take it to the most remote areas in our departments, in the different departments. That's why the microplanning is developed for territory and micro-territory also to urgently respond to outbreaks. We're all working today to control the yellow fever outbreak, and we're on the right path. Thank you very much. Thank you, Jacqueline. Thank you for that presentation and for sharing your experience, and congratulations, because your monitoring is really on top of the situation and allowing you to control the outbreak. So thanks for that, Jacqueline. Let us now move to questions. We have quite a few already in the Q&A. Some have already been answered. So I'll read the questions, and then Carlos Torres, you will decide who is going to answer each question. The first question is from Gianni Quince. Is the guide available for consultation? Yes, I think I've already answered that in my presentation. We're in the editing phase, and in the first quarter of next year, we hope to share the publication with everyone. The next question, again from Yanni, is to know if the local level is the basis for managing microplanning, and what assumptions does that level have to meet, financial, logistic, human? At the local level, well, we know that's basis for microplanning, especially when it comes to operations. Sometimes the resources, and they're obviously dependent on how decentralized the country may be, but it could reach the local levels or even subnational levels, but sometimes they are centralized. Through microplanning, what is done is that the local level must plan how to optimize the resources they receive. That depends, obviously, on whether the country is or not centralized. the goal is to improve access. So what is done here is identify the territory to be covered, the target population that needs to be covered, and then see what resources are available, allowing them to plan or identify gaps, and based on this, be able to bridge them with local social actors sometimes, or with higher government bodies, or as I've said before, it depends on each country's decentralization, but at least they'll be able to identify their resources and their needs. Thank you, Carlos. Then we have a question from Eliana Medina. Good morning. Thank you very much for the excellent presentation. Perhaps expand on these presentations. If there is an internal conflict, which is the tactic recommended for vaccinations? Well, internal conflict, I presume, means to security. The recommendation here is local level. Microplanning, please remember, is to bring down the national reality or that of the territory, but reduce it to the local level. It is not a specific formula in some cases, and again, depending of the sector, it's always important to identify the leaders, the spokespeople for the localities, for the populations, and thus see the best approach. Sometimes it might be through a fixed unit, or sometimes it's going house to house accompanied by a community leader. Sometimes it's calling upon the health services staff. The situations are different always, but what is important to identify them, and that is something that the microplanning instrument does, to identify the social actors, the leaders for certain communities, who are the people that can be approached in order to perform this preliminary work, in order to identify the best approach for the community. And the local levels do truly know their territory very thoroughly. Yes, they know what's recommendable, what can be done there, and who to speak to. We have a question from Irene Melamed. Given that microplanning is an action predominantly local, it is possible that inequalities and local resources, differences in resources, in general could be a barrier that maybe cannot be eliminated, but at least reduce or overcome. Yes, as I was pointing out earlier, it's very important, and one of the things that I pointed out as a major challenge for us is that insofar as we implement microplanning, we better understand the territorial dynamics. Part of that recognition shows that there might be new health personnel that are not familiar with the territory, and they don't really understand how far they can go. So once that territory is well known, one can understand the difficulties to reach out and what resources are needed to do so. That will allow us to identify gaps. But sometimes it's not only the gaps, but also a surplus of resources, because we also must pay attention to that. We maybe have a camera at a local level, where a cold chamber when simply a fridge is needed, a refrigerator, or there are more or perhaps less human resources. So it's important to understand all this in order to truly find the gaps and how we can perhaps reassign those resources or relocate them, not only to reduce but also to eliminate these differences, to smooth them out. Thank you very much. Solange Kobe-Jackson is asking in English, is it relevant using both microplanning tool for routine and for campaign, and how can we merge the two? Thank you very much, Solange, for that question. From PAHO, we recommend to start with routine microplanning in order to then progress to campaigns when planned, as well as outbreak responses Colombia just presented. But Marcela, perhaps the colleagues from Paraguay could respond to this question. hopefully one can allow them to take the floor, or Juan Luis, I don't know if Pablo, Luis, they can better respond to this question because they implemented first routine and then the campaign, so they are better equipped to answer that. Pablo, are you still connected? Are you ready? Would you like to answer, or Luis? Well, if not, we'll leave this question pending for the time being because we're running out of time. So let's move on a little bit. The next question is from Juan Baldeón. To determine the risk in the microplanning phase 1, it must be evaluated through social democratic and vaccination coverage indicators. Now, these changes depending on the use context, whether it is vaccination routine, vaccination campaign, or outbreak response. This is very important. This is what we do in the prior tool when adapting the tool, and the countries tell us what the risk criteria may be. Obviously, they differ in routine, where the entire program is looked at. There are criteria here that are more generic to tackle the routine program, whereas in the case of an outbreak, they have to change because it depends on the specific disease that we are responding to. Likewise, with the follow-up campaigns, these might be addressing or targeting specific population and also perhaps specific vaccines. So the risk analysis changes depending on the strategy to be implemented, whether it will be routine vaccination campaign or outbreak response. So these variables are determined by the country. The country are the ones, after all, who can determine the risk criteria. And the tool will be based on the points given to each category in order to determine the priority. I see Luis has asked for the floor, so I think he's ready to respond to the previous question that we had received from Solange. Luis, good afternoon, and I'm very happy to join this webinar. It's very interesting given the topic. And today we can state that routine microplanning not only improved the coverage, but it also transforms the way that the health units work, reinforcing links with the communities, especially at the primary health care. We're talking here of the family health centers that have a certain population in a given territory. So the process not only improved the distribution of resources, but also improved knowledge about the communities, about the demographic and cultural dynamic, to truly identify the barriers to access health services. In particular, it has helped us to improve our coverage rates for the dose 2 for measles vaccine. We had a 10% improvement, and we have also been working on the desertion rate, and we have reduced it to less than 15%, and today we're closer to 8%. So the key is to work at the local level. The staff is committed, but they also need to feel supported with tools that allow them to plan and in particular monitor the indicators. So that is what we wanted to share with you as to Paraguay's experience. Over. Well, thank you very much. And for those who don't know it, Hugo Luis, known also as Luis, is known as head of Paraguay's immunization program. We have time for another couple of questions to then move on to the next point of our agenda. Juan Baldeón asks, from your experience, is it better to implement local microplanning through steps, or the 4 phases need to be implemented simultaneously at the local level? Well, microplanning, for it to be microplanning, must meet the 4 phases. At least that is the proposal that we are suggesting. I presume that's what Juan is referring to. So first phase is analysis of the situation, second is programming, third is monitoring of implementation so that it doesn't become standard microplanning, and so monitoring, the third phase, will see what actions are implemented and then the results obtained. And the last one is evaluation to see whether the indicators truly improved, as we just heard from Hugo Luis in the case of Paraguay. So take a look at the indicators to see what the behavior has been and be able to see if there has been any improvement in order to move to the following years having better results. We have a question here, but it's not addressed to you, Carlo, but to any one of the country presenters. Sandy, Pablo, or Jacqueline, or Luis also, if he wishes to answer. Leticia Marquez asks, for those who shared experiences, the local denominators, and I know this is both nationally as well as locally. These denominators need to be as broken as possible. Are they from the census, or from what sources did you obtain them? Did you see a lot of bias compared to what is then seen once you're out in the territories? I don't know if one of the three could share their experience. Jacqueline. With the outbreak, we did have the normal census that you have for any territory allowing us to go out. But since this is an outbreak control, we needed to do a house-by-house census to verify who was vaccinated, who was not, and that way assess the true coverage in the territory. We used two censuses, the first of the local level, and then it had to be evaluated and compared to the reality out on the field. Thank you, Jacqueline. Sandy, Pablo, would you like to share your experiences? If not, yes, go ahead. Yes, Marce. When it comes to the population denominator, this is truly an important challenge. Each health service has its own local census, and they work on it. Annually they check it. But when we have the census from the National Statistics Institute, we see there are major differences. In the case of Paraguay, the National Institute breaks down the population region based on the census and has a breakdown to the level of district, but not of health centers. And that is what we need to really tackle, the health centers. Yes, usually the census is reached to the municipal or district level, and then further down, it becomes the task of the territory itself to adapt its methodology to be able to break it down even further. We have a comment from Marta Orquera in Argentina. In Argentina, we have the social health agents that seek out to recruit people who are not vaccinated or live in distant areas. We didn't hear from Argentina today, but it's good to know that they are also implementing microplanning. Carlos, given time, there are some questions that have not yet been answered, but yes, we're answering them gradually, and we'll be able to continue answering them afterwards. Yes, when the material is shared with everyone, we could also reflect these questions. They are truly wonderful questions, but they frequently occur to countries when they want to implement the microplanning. So I think it would be an excellent idea to share them with all the audience afterwards. Marcela, let me clarify something. In my presentation, I said that each of the implementation phases, from adaptation through training and then the monitoring, and we are providing support, but all of this takes time. It might be 1, 2, 3, even 4 months. But when we talk about a tool for the outbreak, that time is obviously reduced drastically down to 1 or 2 weeks, because we have to have effective response. So countries could begin with routine microplanning. That way they'll have all the prior information, recognition of territories, and then afterwards it will be easier to then move to the campaign, microplanning, and even to outbreaks, and hopefully this will be needed much less. Let us have perhaps the campaign, the routine first, and then the campaign, and that will respond to everything. Well, thank you very much, and thank you to all the presenters. Your presentations were wonderful. We'll be sharing them with everyone afterwards. So, continuing with our agenda, I'd now like to offer the floor to Dr. Hugo Rasuri, our Assistant Program Manager at the regional level. Are you connected, Hugo? Yes, yes, I'm here, Marcela. So thank you very much. First of all, I'd like to thank Carlos and you for facilitating this webinar. I was unable to join you right at the beginning. I believe Carlos welcomed you all, but midway through the webinar I was able to connect, and I have been enjoying the detail and qualities that we saw in the presentations, plus comments and questions. There are a few things I wanted to share with you. First of all, I have the greetings of Dr. Daniel Salas, Executive Manager of our program, who had a time constraint and therefore could not join us. But he wants me to express his gratitude to all those present for your support provided to immunizations in the region, and in particular this type of initiative that we are able to suggest and support, but those who truly bring them to life and make them useful on the ground are you, the participants. So greetings to the colleagues from all the immunization programs throughout the region, our colleagues from the country offices in each of the countries. Greetings also to my colleagues here in Washington who are connected. In the audience, we also have colleagues from other organizations such as UNICEF. So I truly believe this has been a very interesting meeting. As you know, in the cooperation plan that we have for integral immunization, we support a number of priorities and strategies that have to do with immunization. It might be information systems, surveillance for preventable diseases. And what brings us together today in particular is how to improve coverage of vaccination in the region and how we can deploy these vaccines more efficiently to all people throughout their life cycle. So methodologies such as microplanning, amongst others, that we also support, these are extremely useful, as many have pointed out, very helpful to identify gaps, how to maximize resources. In a dynamic that not only brings on board experience, which we know is very rich throughout the region, but it also tackles the problem in a systematic way based on information. It's also well ordered, organized, and it is replicable at all levels, as we've pointed out. There are a few things that have been mentioned today that are worth reiterating, such as the importance of adapting these tools to the local levels. That has been stated very clearly and strongly. We are working with our team. I was talking to Carlos yesterday about this, how to better optimize these tools to ensure that flexibility is built into them. These tools, after all, have to be applied in different contexts and with different capacity and time available, as well as the human resources. There are some good examples in the region is how this type of methodology can be truly integrated in the EPI program so that it can become sustainable. With Dr. Salas's team, we insist that it's wonderful to see some specific experiences and to learn from the intense support in deploying a tool in a given context. But the true goal is for these tools to become part of the daily or day-to-day work in each country. And that, I think, has also been reflected through the experiences shared today. Let me thank the country colleagues who presented their experiences today, the colleagues from Guatemala, Colombia, and Paraguay, because they have collaborated in this effort not only to learn in the context of our countries, but also to underscore this spirit that for us is a guiding principle at PAHO's regional collaboration, how we can support one another and how we can continue improving as we move forward. So once again, thank you very much to all those involved in the webinar, and I do hope it was very useful for each and every one of you. Thank you very much. Thank you, Hugo. And before leaving, Carlos, I do believe you want to make a very specific request. Yes, Carlos. Carlos Castañeda, please go ahead. Yes, the idea is to invite you in part of this process to strengthen microplanning in the region. What we're asking you through the different immunization programs and at all the different levels, including the local level, where it is even more relevant to be familiar with the process. To respond to this survey on the use and lessons learned from the microplanning process for immunizations in the region. It's a short survey. In 15 minutes you can answer it to explain how microplanning has been used by you, what tools have you used, whether it's PAHO's or your own, and in particular to develop a roadmap to see what countries or what localities in each country are interested in PAHO supporting you to deploy microplanning in the near future. The survey can be found in this link, or you can scan the QR code. We'll also send you the link, and this survey is both in English and Spanish. On the upper right-hand corner you can select your language, and it will just require 15 minutes for you to complete the survey. We will also share the recording with you. We will also once again provide the survey. This survey is extremely important to all of us, and I do apologize to those countries who have already responded. There are a number of countries who implemented the tool. They would have liked to participate, but sometimes we do have time constraints not allowing everybody to share their experience. But we will continue supporting you throughout the process, and especially the experiences you have can be shared with us so we can see what adjustments to make to the tool. As I always tell the countries with whom we started this work, this tool belongs to you. It's a tool that PAHO is very happy to share with you, and what we truly would like to see is that it will improve the coverage, decrease the gaps, and especially achieve greater vaccination equity. So thank you all, and we will continue collaborating with you and are also always available to you. So thank you, Carlos, thank you, presenters, thank you, interpreters, and thank you, administrative team who constantly support webinars. So we are finishing in a very timely manner. We thank you all for your presence and for having spent the morning with us. Yes, thank you all. And greetings to all.